Hi, everyone. Thank you for joining our symposium today. My name is Weiwen Zeng, and I'm currently a PhD student at the University of Texas at Austin Steve Hicks School of Social Work, and I'm the symposium chair today. Our symposium focuses on parenting interventions for diverse and low-resource families and communities. We all know that parents are central to supporting children with autism spectrum disorders and other developmental disabilities in assessing diagnostic and early intervention services. We have seen a spike in research utilizing parents as a medium in interventions. Current empirical evidence show that parenting interventions are associated with positive child and family outcomes, such as reduced challenging behaviors, increased parent and child interaction, and reduced parental depressive symptoms. However, we consistently see that most parenting interventions were designed for mainstreamed or middle-class white families. It is a huge challenge for most racially and ethnically diverse families of children with ASD who often live in low-resource rural areas to assess these interventions. Today, we had the honor to premiere the most up-to-date research on the development and evaluation of the feasibility, acceptability, efficacy, and effectiveness of 3 different interventions that aim to improve the quality of life of many diverse and low-resource families of children with ASD. These interventions use innovative and accessible methods to target a wide range of disparities faced by families, including challenges brought by the COVID-19 pandemic. Our first presentation will be given by Dr. Megan Kunze. Dr. Kunze is a postdoctoral scholar at the Center for Brain Injury Research and Training at the University of Oregon. Her presentation will feature the pilot test of telehealth as a means to connect underserved families and to assess how coaching for parents could positively affect children's behavioral outcomes. Our second presentation will be given by Dr. Sandra Vanegas. Dr. Vanegas is an assistant professor at Texas State University School of Social Work. She will talk about the development, pilot implementation, and evaluation of a culturally informed parent-mediated intervention for families of children living in low-resource communities. And I will be delivering the third presentation. In my presentation, I will talk about the research findings from a 2-site randomized control trial study evaluating a culturally tailored parent education program for Latinx families of children with ASD in the United States. In particular, I will talk about how our culturally tailored intervention program could maintain positive impact on parent and child outcomes over a longer period of time after the intervention was ended. And last but not least, we have the honor of having Dr. Sarah Dababnah as our discussant today. Dr. Dababnah is currently an associate professor at the University of Maryland School of Social Work. Dr. Dababnah is an internationally renowned expert in services and support for diverse families of children with developmental disabilities. We will be able to hear from her perspective today. Thank you, Sarah, for agreeing to be our discussant. So let's start our symposium. I will hand over the time to our first presenter, Dr. Kunze. Dr. Kunze, please say hi to our audience.
Hello, thank you. And thank you for controlling the slides. And if you want to go ahead and put it on presenter view, that'd be fine for my perspective. Wonderful. Thank you for joining us today. I'm Megan Kunze, and I am sharing about my study, Coaching via Telehealth, Caregiver-Mediated Intervention for Toddlers on a Waitlist for an Autism Diagnosis. I'd like to acknowledge the assistance of Dr. Wendy Mahalachek in her guidance and expertise in this project. I'd like to also acknowledge Chi Wei and Stephanie St. Joseph for their assistance in data collection and statistical analysis. Next slide, please. There are several points of concern around early diagnosis of ASD that should be highlighted. Rising rates, early concern around 12 months of age from a parent, Reliable diagnosis can be made even before age 2. Yet the average age in the United States is still around 4 years old, and even later for children of color. This surge in need of diagnostic services, the lag in time from concern to assessment, results in wait times that are often longer than 1 year. Next slide, please. These long wait times are a problem. Diagnosis allows access to intervention. Waiting for a diagnosis negatively impacts families. During this wait time, parents report limited skills in addressing challenging behaviors, limited access to intervention services that specifically target ASD symptomology, all of which increase parent stress. Next slide, please. While autism-specific early intervention does exist, it is common for these interventions to focus on social communication with less focus on restrictive and repetitive behaviors. Of specific interest in this study are inflexible behaviors, which are considered higher order restrictive and repetitive behaviors. Inflexibility due to unwelcome transitions, such as a diaper change or change to mealtime, may elicit these challenging behaviors. Inflexibility may prevent play interactions, for example, a child's rejection of a caregiver's bid to play, leading to fewer social bids by the parent and more isolate child play. Many intervention studies targeting inflexibility are researcher-led, with only a few including caregiver-mediated interventions. Evidence-based practices to address inflexibility do actually include such interventions as response interruption and redirection, response cost, video modeling, none of which are evidence-based for toddlers and are likely questionable for this age group. Next slide, please. So in this study, we had 6 mother-child dyads that were paired with a coach via telehealth. The child participants were between 18 and 35 months. They demonstrated inflexible behaviors and were on a wait list for an autism diagnosis. All families that participated were considered underserved, meaning that their child received minimal early intervention, which was equal to or less than 2 hours of one-on-one or group early intervention each week. Some of the participants did attend a general daycare, but there was no specific intervention included during that time. Families considered under-resourced were self-reported. They self-reported their financial situation as never having enough money, and rural families met criteria defined by the US Census Bureau. So using a concurrent multiple baseline design across participants, caregivers were coached to use 4 evidence-based applied behavior analytic strategies to target these inflexible behaviors. Those strategies included modeling, prompting, reinforcement, and response interruption and redirection. Each dyad received 15 intervention sessions that lasted about 30 minutes. Data was taken during a 10-minute uncoached play session where child behaviors were tracked using a 10-second partial interval, and parent strategy use was tracked using frequency count. 5 participants completed the study with increases in flexible child behavior and parent strategy use, and all children decreased their inflexible behavior. Next slide, please. A closer look at the participant characteristics. In the first column, you see the dyad's name, the child gender and age. And then next is the qualifying category and marital status. So the first 3 dyads here were all single, while the other 3 were married. All dyads qualified under that underserved, with 2 that additionally met the under-resourced category, and then 1 is rural. Race for each dyad, 3 reported as white and 2 as part of the Latinx community, with 1 identifying as indigenous to North America. In the time column, you see the amount of time each child was on the wait list for a diagnosis, and then if they actually did receive a diagnosis of ASD. Listed next are their pre-diagnosis categories, and then in that final column, you'll see their focus behaviors. And these were identified using the scale, the repetitive behavior scale, the early childhood version. And 2 targets were identified by mom as being inflexible behaviors that they would like to decrease. They also identified flexible behaviors to increase. And these were examples that mom said they would like to see their child use more frequently to assist in play engagement. So here's the data from the 5 dyads that completed the study, and to orient you towards the graph. The primary y-axis is the percent of flexible and inflexible behavior for 10-second interval. The secondary y-axis is the number of sequence strategies used by the parent, and then the x-axis is the sessions. So within each colored circle that you see there, you see the increase of the parent strategy use and the increase of the child flexible behavior. Sorry, I didn't have you switch the slide. Sorry, but thank you for picking up on that non-prompt. So look, now you can see the graph. So looking in those colored circles there, you see the increase of the parent strategy use and the increase in flexible behavior for each dyad. You can also see that the child's inflexible behavior is decreasing to near 0 levels, and that's that line that gets closer during the intervention, closer to the x-axis there. And then looking at the table with the TAU data, you see 3 of the 5 participants demonstrate a strong basic effect between the use of parent strategy use and their flexible behavior. Allie was one participant. She had a medium to high basic effect, and then Daisy was the exception with a weak basic effect between intervention and her flexible behavior. So if you go back to the graphs, looking at Daisy's graph in particular, you see that she had high flexible behavior in baseline as well, which may account for the less change between baseline and intervention for her. And then all participants demonstrated a strong basic effect with inflexible behavior. Next slide, please. Because COVID hit midway through the study, I used a COVID questionnaire to acknowledge each family's early experiences. It's important to remember that this data was from last May, so May 2020, but still you can see how some of the numbers are high here. You see that 3 of the 5 participants rated as experiencing 3 COVID-19 situations. And all participants experienced an increase in responsibilities at home, and that's in that orange circle there in the middle. Next slide, please. Looking at some of the pre-post measures, self-efficacy ratings increased between pre and post, except for Maria, and her scores decreased. We'll talk a little bit more about Maria in the next couple of slides. Next slide, please. Overall, stress ratings decreased or stayed below clinical levels of stress with some exceptions. So looking at Liz's score, and so she's in the center there, that center bottom red circle. Liz increased in 3 areas, and for a difficult child, her score increased to a clinically significant level at post-intervention. So during the intervention, Liz did return to work after 2 months at home, and this required her to work night shifts. So this change in schedule for her may have contributed to an increase in child challenging behavior at home. In a systematic review by Shalev and colleagues in 2020, the authors identified parents with high stress, low economic status, and a child with autism characteristics had less significant outcomes when they participated in parent-mediated early intervention. And this really fits the description of Liz and Daisy as a dyad. They were the only dyad with a weak effect for child flexible behaviors combined with an increase in stress. Additionally, Liz reported Daisy's behavior was a strong contributor to her stress. And then looking at Maria, which are those 2 red circles all the way to the side there, that last column, Maria increased her stress in all areas, with parental distress and difficult child increasing to clinical levels. Maria was the primary caregiver for her twin toddler girls once COVID-19 enforced the stay-at-home orders, and this increased her awareness of her daughter's developmental differences. During intervention conversations with Maria, she shared that she felt guilty that she didn't realize how differently Allie was developing in comparison to her twin sister. Next slide, please. Overall, most participants increased their quality of life scores as well as their subscale scores. An exception was in Maria's quality of life score, which decreased or stayed the same. Looking at her score on disability support, Maria shared her disappointment with the lack of available services for her daughter. She also had high stress scores as the highest number of COVID-related experiences. And then as shown in the orange circle, the scores for emotional well-being subscale were the lowest scores. And this subscale included questions around relieving stress, having supportive friends, free time, and respite care. And past research certainly suggests that parenting a child with special needs is emotionally difficult. And this sample echoes these findings. Next slide, please. A few takeaways from this study. First, using parent-mediated intervention to focus on core difficulties, both social communication and flexibility, is recommended. This intervention took place in the home environment. Sorry about that, the leaf blower is going off outside, so I just was trying to, but we may have to. But this intervention took place in the home environment, demonstrating positive outcomes for virtual parent coaching in the natural context. A second outcome, this study was planned and delivered virtually via telehealth. It is unknown that the pandemic would make virtual intervention the standard. During the study, parents shared their diverse experiences, including the lack of quality intervention delivered over telehealth by other providers. So virtual delivery of quality parent coaching strategies can increase quality of life, self-efficacy, and decrease parent stress. And the key word in that phrase really being quality. And then finally, evidence-based practices for toddler-age children are limited. More specifically, within the category of challenging behaviors, there are some evidence-based practices for toddlers, yet modeling, prompting, and response interruption and redirection are not. In this study, modeling and prompting were found to be effective and acceptable. However, response interruption and redirection was used too infrequently to really draw a conclusion. So future research should continue to establish the effectiveness and appropriateness of additional practices for underserved toddlers. So thank you, and I look forward to questions and discussion.
All right, and our next presenter is Dr. Sandra Vanegas. Sandra, you can start your presentation. Just give me a second.
Okay, great, thank you. So today I'll be talking about the development and pilot implementation of the AAFZ Screening and Parent Engagement Intervention Program in low resource communities. Next slide, please. So we know from the literature that there are significant risk factors associated with low resource communities. This can include unstable housing. Many children and families may have inadequate insurance coverage, meaning either they have no insurance or the insurance coverage that they have is not sufficient to cover the needed healthcare services. There may be also issues of food insecurity, as well as other high risk factors and low protective factors within these low resource communities. When we think about autism services, we can think about how all of these risk factors might impact the access and availability of these services for young children and families. For example, we know that many screening and diagnostic instruments come at a cost, meaning that many clinics in these areas may not have the funds available to acquire these instruments or these tools to screen children with developmental concerns. Within these communities, there may also be a lower availability of providers who are trained and qualified to screen and diagnose children with autism, or even provide services for children with autism. If these communities are in racial, ethnic, or linguistically diverse communities, there may also be a lower availability of providers who are bilingual or who are proficient in serving diverse families. So all of this really means that children and families who live in these low resource communities may have lower access to evidence-based treatments, interventions, as well as special education supports. So we know that these are needed services for improving the long-term outcomes of children and families. So there So there is a significant need for creating programs that are not only available to families and low resource communities, but that have been developed with these communities in mind. Next slide, please. So we set out to develop the Aspen Intervention Program, building on existing programs that had been previously developed and validated with either children and families, and as well as racial ethnic minority families. Because we wanted to fully engage families and low resource communities, we began the process by engaging stakeholders. We worked closely with 2 families who had a young child with autism. These families had also participated in prior parent education programs or parent-mediated intervention programs, so they were familiar with some of the content and strategies that could be taught to parents to support children with autism. We work closely with them in presenting information, content, as well as strategies that we thought would be helpful for teaching families in these communities. And we just really wanted to make sure that these strategies and this information were things that would be readily implemented at home and that fit within the family's daily routines. Throughout this process, we obtained parent feedback on different strategies that we discussed, as well as content, and they provided recommendations on how to improve the materials so that they would be more accessible to other families of young children with autism. Overall, families reported that the strategies were very easy to implement in daily routines. Many of them were things that they were already doing with their child. And they had some recommendations on increasing the number of images and video examples so that it was much more clear to them what we meant by different strategies, or even just picture examples of what we expected a child to do. We had some development of the materials in Spanish already, and we've had some clarification to make sure that the Spanish terms that were used were accessible. And then there was also a request for community building for families. They wanted to know that there were other families who were in the same situation as them. They wanted to have those opportunities. So we took all of this information and we modified the program curriculum. Next slide, please. So we developed this curriculum to really address the needs of families in these low resource communities. We began the program by identifying stressors and different strategies to address stress that families could encounter, as well as highlighting social support networks to help address stress that parents might encounter. We felt that we needed a significant portion of the program devoted to a psychoeducation on child development, so that families would have the information, that foundational knowledge on, why are we doing the strategies, or why are we implementing these strategies with children to improve their outcomes. We then covered developmental strategies and behavioral strategies. We provided coaching to parents on using these strategies at home. And finally, we concluded with an overview of how to use these strategies and how to apply them in everyday settings. Next slide, please. So we set out to work with low resource families. We had developed all our materials in English and Spanish. So we were primarily focused on those 2 languages. We were also focused on young children under 6 years of age, or at 6 years of age or younger, so we could reach that pivotal age in child development. We recognize that many children may not have an autism diagnosis, or they may be on wait lists for a diagnostic assessment. So we did not make that an inclusionary criteria, but they could be at risk based on autism screening instruments that we would implement. And then we also focused on children who resided in low resource households. This means that either the child or the family had Medicaid as their insurance provider, the primary caregiver had a high school or lower education, or the household income was 200% of the federal poverty level or lower. Next slide, please. So we did the pilot implementation of the Aspen intervention in 2 phases. In phase 1, we took all the recommendations and decided to implement it in group format. The intervention was delivered by a student clinician and a peer leader, so a parent of a child with a disability. And these are the demographic characteristics of the participating families in phase 1. About half of the group was primarily English speaking. Children were about under 3 years of age, primarily males. There were still primarily Latino families. And then as what you'll notice at the very bottom is we have the average number of sessions completed. So we had 12 sessions in the intervention program. And in this group setting format, families on average completed about 8.2 sessions. Next slide, please. So after the intervention, we before and after the intervention, we evaluated child and family outcomes. So here are 2 of our child outcomes before with baseline and post-intervention data. We did see that children reduced their autism symptoms based on the social communication questionnaire. And we also saw some improvement in adaptive behavior between baseline and post-intervention for these families. Next slide, please. In terms of family outcomes, we also assessed parenting stress, and we did see a reduction in parenting stress from baseline to post-intervention. So this suggests that, at least from this intervention, there may be some positive gains for both the child and the family from participating in the Aspen intervention program. And these are very preliminary data, given that these are all based on 5 families. Next slide, please. So we did encounter, in this first phase, we really wanted to look at the feasibility of this program based on the initial family feedback. We were able to establish that community for parents where they could learn from others who had a young child with developmental delays and with autism. And we were able to serve multiple families at one time. However, we encountered some challenges in implementing this intervention. For example, as noted before, families completed about 8 sessions out of 12. So there were several sessions where they missed, and we weren't sure if they had reviewed videos of the sessions they had missed. And then there was also less time to individualize the intervention for the families. So for phase 2, we modified the format. So we went from primarily group with some individual sessions to completely individual sessions. We revised the organization of some of the sessions. We realized that some families needed a bit more time focused on parent education and more focused on the early child developmental milestones. And we also revised the role of peer leaders. So we initially had peer leaders participating in all 12 sessions. We found that that was a very big ask for many families or peer leaders who also had their own child with a disability and worked full time. So we revised their role so that they would be present in the first 2 sessions as well as the last 2 sessions. So this would help anchor their participation in the program, and they would be able to have those important conversations with the participating families. Next slide, please. So in phase 2, and just as a reminder, these were individualized sessions with the families. So in this phase, we had 7 families enrolled. Children were roughly a bit older, almost about 5 years of age. We did have somewhat of a balanced mix between males and female children enrolled in the study, and these were all Spanish-speaking families. And all of the children had an autism diagnosis, even though we did have, it was open for children who did not have an autism diagnosis. Next slide. So one of the things to, as I present these results, to keep in mind is that this study phase 2 began right at the time of COVID. So all of the baseline data that we collected for phase 2 actually took place prior to COVID. However, the intervention and the post-intervention assessments were all collected after COVID or during COVID. So in terms of social communication questionnaire, we did see a slight gain in autism symptoms among children between baseline and post-intervention. We didn't see very much change in adaptive behavior for child outcomes between baseline and post-intervention. Next slide, please. And then when we looked at family outcomes, we did see that stress levels remained pretty consistent between baseline and post-intervention. So it's unclear what impact COVID had on these results, or whether the intervention helped mitigate some of the impact of COVID. And I guess we'll see. We do have follow-up data for these families that is in progress, so we will be able to see whether or not these impacts were sustained in the long term. Next slide. So our next steps, we've learned so far that Aspen is feasible, that we can do it in an individualized format, and the families are responsive to the material and the content. So our next steps are to conduct a randomized clinical trial of this program, which we're currently in the middle of. So for this RCT, we'll have our intervention group, who will receive the 12 individualized sessions with a clinician, a peer leader. And currently these sessions are being delivered over video conferencing. And then our control group will receive 4 check-ins across 12 weeks with a clinician. The idea is that they would receive be receiving a more self-guided version of the program, and the check-ins will be taking place over the phone. So this could be a potential model for clinics or organizations that have fewer resources to be able to provide some support to families of young children with autism. Next slide. So that concludes this presentation. I did want to acknowledge the families who participated, as well as the research team and all our funding agencies that have made this research possible. So thank you, and I look forward to questions and discussion.
All right, thank you, Sandra. Next presentation will be mine. Just give me a second. All right. Hi, everyone. So I will be delivering the 3rd presentation. In my presentation, I will talk about the research findings from a 2-site randomized control trial study evaluating a culturally tailored parent education program for Latinx families of children with ASD living in the United States. In particular, I would talk about how this culturally tailored program will have positive impact even after the program, the intervention is ended. The title of my presentation is Revisiting an RCT Intervention for Latinx Families, Are Effects Maintained Over Time? In a short synopsis, we conducted an evaluation study of the efficacy of a parent psychoeducation program for Latinx families of children with ASD over 3 assessment time points. We know through the literature that Latinx families face profound disparities in services and interventions. Latinx family and children are more likely to report unmet service needs in school and healthcare systems. They are also less likely to receive evidence-based treatments. And oftentimes, existing treatments do not address the needs of Latinx and low-income families. For example, according to a study conducted by Magana and colleagues, compared to white children with ASD, Latinx children are less likely to receive ABA services. They are also less likely to receive regular services, such as this one called Birth to 3. In view of this, our team developed a parent psychoeducation program called Parents Taking Action. PTA is a 14-session psychoeducation program culturally tailored for Latinx families of children with ASD. We train peer leaders, who we call promotores, to deliver the content through weekly home visits to these families. Families have the option of choosing between English and Spanish, meaning that they can do, we offer interventions in both languages. families were considered eligible if they, first of all, were Latinx descent and lived in the two major cities in California and Illinois, which were the two main study sites. Second, they also needed to have a child age 8 years or less that was diagnosed with autism or on a waitlist for diagnosis. We measured three major outcomes, including, first of all, parental confidence in using evidence-based strategies. Second, parental frequency of actually using the evidence-based strategies taught in the program. And we also measured the number of services received by the child before and after the intervention. So here is the PTA curriculum. You can see that the curriculum covers a wide range of topics, including autism and its etiology, the child's problematic behaviors. We also teach the parents to advocacy skills to advocate for the child in the school. We also address challenging behaviors and parental stress and depression in our program. And last but not least, we helped the families, we connect them to other parents and also service agencies that serve Latinx families, to expand their social support network. So here is our RCT design. You see that at baseline, after these families are enrolled, we conducted the time one assessment. And then these families are randomly assigned into treatment groups and control groups. So for the treatment groups, they underwent the 4 months, roughly 14 weeks intervention protocol. And right after the intervention, which is roughly 4 months after the baseline, we assess these family outcomes a second time. And then we waited another 4 months to conduct the time 3 assessment. In this study specifically, we are using linear mixed models to analyze our data collected from the 109 families that are enrolled in our study. So here is some basic demographic information. Let's take a look. So on average, the mother were 27 years old at the time of the study. Most of them had high school or less education. They were mostly unemployed, married, and were foreign born. And their annual household income were mostly below 40,000 US dollars. And the majority of these parents rated their health as good or excellent. In this column, you see that in our Illinois study site, we have a sample of 80 parents, and in the California site, we have 29 parents. For the child demographics, you see that on average, the child were around 5 years old, mostly were male, and roughly about 37% of them have severe ASD symptoms at baseline. We also compare the intervention group and control group to see if there is any pre-existing significant demographics differences at baseline. And the randomization process resulted in a pretty good result. We can see that intervention groups and control groups are comparable across all these demographic matrices. So let's take a look at the first outcome here, which is the confidence, paternal confidence in using evidence-based strategies taught in the program. We see that across the 3 time points, we see a significant increase in terms of the confidence in using evidence-based strategies from time 1 to time 2 and time 3. And the differences at time 2 and time 3 are statistically significant. For the second outcome, we also measured the frequency, the actual use of evidence-based treatment strategies that are taught in our curriculum. Again, similarly, we see a significant increase in the frequency of using evidence-based strategies from baseline to time 2 and time 3. And the differences at time 2 and time 3 are statistically significant for the treatment groups. And then we also measure our third outcome, which is the number of services the child received from baseline to time 3. Again, you see that, you know, at baseline, on average, the child we're receiving about 2.4 services, and that this figure increased to roughly around 4 at time 3. This difference at time 3 is significant, statistically significant between the treatment and control condition, indicating that after the treatment, the child also received more services. An interesting finding in our study is that we detected treatment differences between these two study sites. Let's take a look. So for example, in the California site, we see that the treatment outcomes for the family outcome and also for child outcomes, the California sample seems to have more robust treatment differences across these outcomes. But for the confidence and frequency questionnaire, the measures, we see that the Illinois sample have a larger treatment differences from baseline to time 3 in comparison to the California sample. What does this mean? We think that because of the differences in terms of the services available to these families at both sites, we see we see that in the California sample, these families are felt more empowered. They have more confidence in assessing the service systems for their children, while at the same time, at the Illinois side, the services are often limited, meaning that these parents somehow have to implement the evidence-based strategies themselves rather than assessing the services in the community. And it's all for my presentation. And we are gonna have Dr. Dababnah to give us her discussant remarks.
Hi, thank you so much. Those were all really great. That was just, I'm really, thrilled to be here today and talk about one of my favorite topics, developing parenting interventions for diverse and low resource families and communities. Over my time in this field, I like all of us, we've been a witness to the really stark inequities that face some families raising children with autism and other developmental differences. All families have strengths, all families have challenges, but when faced by external burdens related to immigration status, poverty, geography, racism, and other forms of oppression and discrimination, families' abilities to use those internal strengths and resources is just really hard. And frankly, our field has not done a good job in the past of responding to those challenges. We have an excellent array of interventions for children with autism, but we have very little information on their effectiveness in socioeconomically, racially, and ethnically diverse communities. We also know from services research that there are some, pretty significant racial, ethnic, socioeconomic, and geographic disparities in the access to these interventions. And so I think from a practice standpoint, we could start to understand why. Some interventions require a really high time commitment from families, which, for example, for a single parent working more than one job will have trouble committing to. And I will also say that interventions tend to focus only on the child, which of course should be a central component, but then has the potential to leave out other factors impacting parent and family engagement. of course, there are so many other factors: transportation, internet access, literacy, the cultural relevance of an intervention. I mean, those all get into the way of making interventions more accessible and more inclusive. Of course, COVID has really exacerbated those pre-existing inequities, and the problems that we face in the field are just even greater in so many ways. So I was really excited to hear from these three scholars and their teams who have already been doing the work, to reach underserved communities pre-COVID, and now during the pandemic, they've just really stepped up to do even more. If I may, I'd just like to summarize some notes that I took, just to, the main takeaways from each presentation. Dr. Kunze and her team, they use telehealth to reach underserved families of children waiting to be assessed for autism. And of course, that comes at a very critical time. Diagnostic disparities have been very well documented, but there's been very little research to close the gap and reach kids pre-diagnosis. So I was really heartened to see that improvements in parental stress, which we all know has a tremendous impact on the parents themselves, but also on the children and the whole family. And so those findings really align with the improvements that Dr. Kunze shared in family quality of life and parent self-efficacy. And this work has clearly laid an important foundation for future studies of practices to better serve families, especially given that we know that COVID has had a disproportionately negative impact on communities of color and low-resource communities. I'm quite sure that we can see more telehealth in our future. And so Dr. Kunze and her colleagues have really given us a strong foundation on which to not only reach underserved families, but also to partner with them and build on the strengths that they have. So the second presentation by Dr. Vanegas evaluates the development and implementation of a culturally informed parent-mediated intervention, ASPIN, for families of kids with autism living in low-resource communities. And very few researchers have taken the time to thoughtfully and systematically adapt interventions for culturally diverse communities. And so this work leading up to the larger trial is a time-consuming yet really critical step. And the ways in which that Dr. Vanegas and her colleagues have responded to challenges by modifying sessions, revising facilitator roles, and so on are just really models for the flexibility that we need in our field. Most of the time we expect that families are going to mold themselves to our programs rather than vice versa, and so clearly the participants in this study were satisfied with the program, and they showed some promising trends and the outcomes that they measured. So I think we can all really look forward to seeing the next steps for ASPIN in the clinical trial. And last but that's really not least, the third presentation looked at the maintenance of intervention effects over time for a culturally tailored parent psychoeducation program, Parents Taking Action for Latinx parents of children with autism. I think it's important to differentiate between interventions that aim to reach underserved communities and those that are culturally responsive. Of course, there could be overlap, and I think that PTA, Parents Taking Action, is a really good example of that overlap, which directly responds to the needs of a specific underserved community, Latinx families. And the results of this trial were very promising in terms of parents' use of evidence-based strategies and their confidence in doing so over time. And I think the trial also, for me, also highlighted some of those policy and state level implications for autism intervention research. We can tell parents all that we want about what's effective, but they're really limited, and we're really limited by what's happening in the state. So it's important that we continue to advocate for improved availability and access within our state and local systems of care. So I do want to acknowledge again how difficult this work is. I mean, it's certainly a lot easier to develop and test interventions with families who have more economic resources or fewer external barriers. Yet we can't continue to exclude families because they have barriers. I've often thought about that. Without the strengths that already exist within historically underserved and marginalized communities, the disparities that we do see would probably be even larger. So, I mean, we're really missing a lot of opportunities to build on community strengths and really partner with families when we don't put the work into adapting our practices. So, I mean, I'm really, really grateful that these and other early career researchers are in this work, because it is going to be a long haul. You know, recruitment and retention will probably continue to be a challenge in future studies. So it's really critical that, you know, we as a field are supporting this work that, you know, our colleagues here have done, and that we're all trying to do. I mean, we can't wait. We have to do better to better serve families. So thank you for your time, and I look forward to the questions for our panelists.